Welcome to Module 2A. Today we're going to be talking about hemodynamic monitoring and what that means as a nurse. It goes beyond just measuring normal vital signs. This is especially critical and important for you to know if you go to work in a critical care setting like an ICU, an ER, OR, those kind of places. So some of the objectives we're going to be talking about today, I will let you pause and read all of these, but mostly we're going to go over why we go more into detail on hemodynamic monitoring and setting up the pressure system and some of those different measurements that we are going to talk about that goes beyond just normal vital signs. We're also going to talk about some meds and nursing interventions that would happen based off of if those monitoring values are outside the normal ranges. So the first challenge question we're going to talk about today, remember, just listen to the question and in your mind, pause it, think about your answer, and then go on. And you might change your answer by the time we revisit it, and you might not. So let's just see if you get it right. So the first question is, a patient with a CVP of 3 milligrams of mercury and a blood pressure of 88/58 is receiving diuretics. What should the nurse do next? Or you could say, what should they do first? Okay, so administer a vasopressor, administer a fluid bolus, reassess CVP after 1 hour, or stop the diuretic infusion. So pause this, think about it, don't cheat, but think about how you would answer this question if it was just posed in front of you right now with the knowledge that you know, and let's see if you get it right. Okay, so hemodynamic monitoring is the cornerstone of critical care nursing. It allows us to continuously assess the cardiovascular function of our patients, providing real-time data that guides treatment decisions. This monitoring is so important for detecting complications early, which we all know is the sign of a really good nurse. Some of those things that you want to detect early: shock, heart failure, and we also want to monitor everything in our patients so that we can optimize oxygen delivery and tissue perfusion, like essence of life, right? So hemodynamic monitoring is like having a special tools to help doctors and nurses keep an eye on how well your heart is working and how well it's able to pump blood around your body. Imagine your heart is a pump and your blood is like water flowing through pipes. I know I use this analogy a lot, but let's go. Okay. Hemodynamic monitoring lets us see how strong that pump is, your heart, and how fast the water is moving, your blood, and if the pipes, your blood vessels, are actually working properly. We use different gadgets to measure these and how fast your heart is beating, how much your blood pressure has as it moves through the body, and if there's enough blood flowing to keep your body healthy. Another way to explain it, like you can imagine if you're the nurse and your job is to make sure that the heart and blood vessels in your patient's body are working properly. So think of it like being a mechanic for a car. Just like a mechanic checks the engine oil, tries to make sure the car runs smoothly, you're using these special instruments to monitor how well the heart is pumping blood and how well the blood is flowing through the body. So all of this is called hemodynamic monitoring. Okay, so it involves using those tools that measure things like heart rate, blood pressure, and all those kind of things, and heart pressure, blood rate, yes, and all those kind of things to give you important information about how the body is doing. Okay, so with that said, if the heart isn't pumping strong enough or if the blood pressure is too low, it's going to be your job as the nurse to actually notice it and then take action. You might need to give the patient some medications. You might need to adjust their fluids or work with the doctors and the care team to decide another treatment. Okay, so hemodynamic monitoring is like it's one of the basis of health assessment in an advanced way. Okay. But I always want you to remember the monitor needs to correlate with what your patient looks like. We don't treat the monitor, we treat the patient. So if the monitor says something, does it match with how the patient is presenting in front of you? Okay, so that's always the key. If they're the same, then we act, right? Okay, so moving on. So in critical care, we use a variety of pressure monitoring systems to gather detailed information about different aspects of our patient's cardiovascular and neurological function. So each system has a specific purpose and provides crucial data that helps us guide treatment decisions and what we're going to do first, second, fourth, helps us determine prioritization and all those kind of things. So we're going to go over a few of these right here more in detail. The top three, art line CVP and pulmonary artery pressure, we're going to discuss more in depth versus ICP, IAP, and cardiac pressure monitoring. Now, the bottom three, I'm just mentioning those. We're just going to barely skim over those. I don't want you to super focus on those. I want you to focus on the top three for this course. I just want you to kind of have a general understanding of the last three. So first, we're going to talk about arterial pressure monitoring. We also call these art lines. Okay, arterial pressure monitoring is used to continuously measure a patient's blood pressure directly from an artery. Usually, we're going to use the radial artery, but we might use the femoral or the brachial artery. Okay, so this system is particularly important in the critical care setting for patients who need close monitoring of their blood pressure, such as those that are on like medications that affect vascular tone, those undergoing a major surgery, those patients that are in some form of shock. The system includes an arterial catheter, which is inserted into the artery. And every time you hear the word catheter, just think of straw, like plastic tubing straw. Okay, so it has an arterial catheter, which is inserted into the artery, a transducer that converts the pressure into an electrical signal, and a monitor that displays the pressure as a waveform. These waveforms give us real-time information on systolic, diastolic, mean arterial pressures, helping us make immediate treatment decisions, okay? So you'll often see a lot of times when the art line is like in the radial artery, you're just going to see it there. So don't mistake this for peripheral IV. It should be labeled very clearly. And it looks a little differently, and you're going to see that the line goes to the transducer and the monitor, not your typical other like J-loop peripheral IV. So CVP, what is CVP? CVP is used to, it's central venous pressure. Okay, so think about that. It is a pressure in the central venous system. So think about where those are. Okay, so it's monitoring used to measure the pressure in the right atrium or superior vena cava, which reflects the fluid status and the right ventricular preload. Okay, when you see the word CVP, I want you to think fluid, okay? You're going to think fluid volume. Central venous pressure, fluid volume, okay? This type of monitoring is super important for assessing the patient's fluid balance, right? And right heart function. The system includes a central venous catheter placed in a large vein, venous vein, not artery, right? A transducer, and a monitor that displays the CVP waveform. These waveforms correspond to the phase of the cardiac cycle and provide valuable information about how well the right heart is functioning, and as well as the volume status of the patient. So this is typically we typically use a central line for this. So when a patient has a central venous line, so we use those to give meds and all kinds of stuff like that, especially the meds that are super irritating to blood vessels, or if we need to administer like large amounts of fluid very quickly or blood products very quickly, we want a central line. You hear about central lines all the time. So often they're like double lumen, triple lumen. And what that means is that there's like three little straws, three little catheter like things that all kind of are in a big enclosed tube that go into the body. So it's kind of like having like 3-in-1 kind of thing, right? Well, we can use one of those ports to hook it up to the transducer and the monitor to measure, and we can use the other two or one, depending if it's double or triple, to administer meds and fluids and stuff like that. So pulmonary artery pressure, PAP monitoring, okay? So it involves the use of a pulmonary artery catheter, commonly known as a Swan-Ganz, to measure pressures within the pulmonary artery. This provides such important information about how the left side of the heart function is and the pulmonary circulation, which is especially important in managing patients with heart failure, pulmonary hypertension, or shock. The PAP monitoring system includes the catheter, which is threaded through the right side of the heart into the pulmonary artery, transducer, and the monitor that displays the waveforms. Okay, and it includes the pulmonary artery pressure and pulmonary artery occlusion pressure, which is also called wedge pressures. So you might hear the word wedge pressure, and that's the pulmonary artery occlusion pressure. These waveforms help us assess both the right and the left heart function, guiding our treatments and what we're going to do with our meds and how we're going to take care of our patient. I'm going to be honest with you. ER nurses go swan gans, huh? This is not something that an ER nurse typically does. So I will tell you that I am weak in this area when it comes to like interpreting results, because like I said, this is more of somebody's undergoing like some massive 16-hour cardiothoracic surgery, or they're in the ICU, intubated, super sick kind of situation. Very rarely. In fact, I have never seen this monitoring in the ER. The ER does art lines. If you can convince somebody to throw an art line in for you, you're like, thank you. Like, because it makes your life so much easier. Real time, like minute by minute, second by second, what the blood pressure is in the body. CVPs, I've only ever measured CVPs at more acute hospitals, like teaching facilities, more rural community hospitals, the ER. That's just kind of something that nobody thinks they have time for in the ER, and they're just going to wait to send the patient upstairs, but it's better to have it. But pulmonary artery pressure is definitely an ICU, OR kind of only type situation. Okay, so some of the other monitoring, intracranial pressure. If you go on a neuro ICU, you're going to see this, and it's going to be like sometimes they can insert these at bedside. It's kind of crazy to watch. Intra-abdominal pressure and intracardiac pressure monitoring. So, y'all, I just want you to just look up some of these definitions. Just kind of understand what it's doing. The ICP, or intracranial pressure, is probably the one you're most familiar with at this point, if you're familiar with any of these three. So that's the one that is used to measure the pressure inside of your skull. Remember, your skull is an enclosed space. If something gets bigger, something's got to give. And the only thing that's really got to give is the tissue coming out, and it doesn't happen, and it's bad, and we'll call that herniation. We'll talk all about it when we go into our neuro lecture. Anyways, intra-abdominal pressure monitoring is the pressure obviously inside the abdominal cavity, and it helps us detect and prevent serious complications and stuff, including like abdominal compartment syndrome, which can be seen in like trauma or post-surgical patients. The intracardiac pressure monitoring is used during procedures like a cardiac cath. So if you want to go work ICU, cardiac cath lab, which are super interesting places to work, you'll be more in tuned with these. So it measures the pressure within each of the heart chambers. That helps the care team diagnose and manage more complex, specific heart conditions. So just kind of know what those are, just general terms. So understanding the pressure monitoring system. So like I have a picture here on the screen, if you look at this, where it's kind of like a generic picture. This is really, these are the words that I already kind of said in before, but you just so you know, a transducer. If you look right there in the middle, it says a 3-way stopcock. That's the thing that it can turn on or off a line. It's kind of like a valve. Think of that as a valve, like it lets fluids flow, or you can stop it. The transducer is the thing that has the electrodes kind of thing that's actually measuring something inside the tube. So you see the transducer is kind of halfway there, right? The catheter, remember catheter, same thing, kind of like lumen. It's the plastic tube that goes into the blood vessels or into the body. Obviously, you know what a monitor is, okay? So oftentimes, the same cardiac monitor that's up on the wall that does the blood pressure and the heart rate and all that kind of stuff, if you have the right cords to plug into the electrical cable for the art line or the CVP or whatever, then they all plug in. If you ever look on the side of those monitors, there's a whole bunch of little port plugs and different things, and they should be labeled. And I will tell you again, the ER, it's good luck finding the cords. They grow legs and walk away, but the ICU should have them, and they typically like zip tie those suckers and they don't let them go anywhere because they're really expensive. But you need the cable and to the actual monitor, and most monitors will give you the reportings of like your art line, your CVP, all those kind of things. Okay. And then there's typically a flush system, which is typically an IV bag with a pressure bag. So IV fluids with a pressure bag that kind of has a constant gentle squeeze per se. And it typically, like, it just lets a little bit of fluid go through, just like 3 mLs an hour typically. And that helps prevent clotting and maintains the patency of the catheter, because blood, you don't want it to clot, then you're not going to get an accurate reading, right? So, nurse's role in pressure waveform accuracy. We are super responsible for everything that we assess, right? Okay, so ensuring that accurate pressure waveforms is basically one of our key responsibilities as nurses when we're dealing with hemodynamic monitoring. This starts with zeroing out the transducer to the atmospheric pressure. So before you hook it up, you zero it out. Okay, it's kind of like a scale. You want to zero it out before you put the thing on to measure it. You want to zero it out before you hook it up to the patient to measure it. Okay, so you will be trained wherever you go to work on how to do this based off of your specific monitors and cables and what equipment is actually in your facility. So don't worry about those specifics. Just remember, you always zero it out before you hook it up. Okay. So the transducer also must be positioned at the phlebostatic axis. What is that? That is a really long word. So what that is go over here in just a second, but it's approximately the fourth intercostal space mid-axillary line. Okay, so it corresponds with basically the same level of the atria of the heart. Okay, so we want to have it on the same level. I have a picture to show you. Just hold on a hot second. It's also super important for you to check for air bubbles, because if there's air bubbles in the system, you're not going to get accurate readings. And you also just want to calibrate and troubleshoot if things look a little wonky on the monitor and it doesn't match with what the patient looks like, or your assessment, your physical assessment of the patient. Always, obviously make them look the same. So if we go back to that picture before, if you look at the patient, so it's much easier if they're lying flat, but sometimes that may not be indicated. So like that you might want the head of the bed raised at a 30-degree angle or something like that. So if you see over on the left-hand side where the patient is, you'll see a red kind of cross. That's basically the fourth intercostal space at the sternum, midpoint axillary. And that's kind of you see how that now right where they cross, you see now a black line that goes across, and it's the same level as the transducer. So we want to keep that, and you do not want to tape it to the bedside rail. Don't do that. But there's typically these like little setups that you can hook around the IV pole that can go up and down the pole, that you can adjust the level that transducer kind of sits at on that line. So you just want to make sure that you're keeping that transducer at the phlebostatic axis. If they're lying flat, it's pretty easy because it's basically like halfway between like anterior posterior chest. But like you don't want it above the patient or below the patient. You kind of want to keep it in line. Okay, so that's that. Okay, so specific to arterial pressure monitoring. So if we're putting an art line in, there are some complications that can happen. So we're putting it in an artery, which has higher pressure than a vein. Okay, right? So there's always going to be a risk of bleeding at the insertion site. Obviously, we're poking through skin, so there's always a risk for infection and thrombosis, so clot formation in the artery. But a big thing is also ischemia, which could happen if you somehow don't assess if it was the right place to put it from the get-go. So if y'all remember Allen's test, you should already remember Allen's test from health assessment. But if you don't, there's a little picture on the screen to remind you. Okay, so basically you do this before you place an art line, because we want to make sure both the ulnar artery and the radial artery are freely flowing and supplying that hand with blood. Because let's just say hypothetically, if there is a blockage or the ulnar artery is damaged, and then we go put a catheter in the radial artery and we mess that one up, then how is the hand going to get blood? It's not. And then we have a whole series of other complications. So what you do is you're going to occlude both arteries. You push down and occlude them. So you're pressing down so hard that basically the hand's going to turn numb and white and kind of blanch. Okay. And then you're going to release the ulnar artery, the one that we're not going to poke with the art line, because we want to make sure that the hand turns pink again and that blood flows, because then that means ulnar artery, good. So now we can release the radial artery, but we can now poke the radial artery. Okay. So that's what Allen's test is, just as our memory. Okay, so now let's talk about CVP, or central venous pressure. Okay, I hope you guys are sticking with me now. I know it's a lot of information, but I promise you, once you start interacting with these different monitoring types, you will understand. I promise. I promise. So remember, it's beyond just MAP, blood pressure, heart rate, pulse ox. There's so many more vital signs you could be monitoring. So CVP, it's one of my favorites. It's a monitoring, basically what CVP is, an essential tool for assessing the right arterial pressure and the venous return. And what did I say? Fluid status, right? So the normal range for CVP is between 2 and 8 milligrams of mercury. So 2 to 8. That means if the monitor is showing between 2 and 8, that means that they have a decent cardiac function, and the amount of fluid in the tubes in the system is normal, whatever normal means, but it's normal. Okay. So values outside that range can indicate several different issues. So a low CVP might suggest hypovolemia or dehydration, while a high CVP could point to fluid overload or right-sided heart failure. Okay. So pause that and listen to that again if that doesn't make sense to you. So think about how the blood flows through the heart, and if there's not a lot of blood in the tubes, if there's not fluid in the tubes, or if there's a lot of fluid in the tubes, how that indicates what's going on, or what may be the cause of vital sign changes, right? So CVP readings help us make decisions about fluid management and drug therapy, ensuring that our interventions are tailored to the patient's specific needs. I will tell you, when your patient is in shock, especially like septic shock, your physicians are going to be asking for continuous CVP monitoring, and they're going to be giving you orders based off of the CVP. And they may or may not, they may just ask for CVP, and then you need to know based off of what the CVP is, what to ask for the physician. We'll go more over that in a little bit. Remember, CVP fluid. Okay, so similar to the ART lines, there are some risks associated with monitoring CVP. So it's remember, CVP, it's not through an ART line, like an arterial line. We're going through a central line, a central venous into a vein, like the superior vena cava, like that kind of thing. So, so while CVP is valuable, it does carry those risks. Infection is always going to be one of those due to it just being in the central line. So every time you hook up to a central line, you want to make sure that you're aseptic and clean, because we don't want to introduce any pathogens into the bloodstream. There's always a risk for thrombosis or clot formation, which can occur at the catheter tip. And it can also potentially obstruct the vein and lead to an embolism in the body. And we don't want that. There's also a risk for pneumothorax during the insertion of the actual central line, especially if it's placed in the subclavian or IJV, or the internal jugular vein. One of the most serious complications, though, of it, placing a central line is an air embolism, which can occur if air is accidentally introduced into the line. That's why we always pull back before we push. This is why it's super important to maintain a closed system and be vigilant during manipulations. Now, if somebody has a peripheral IV line in their hand, or AC, and there's little bubbles in the tubing, it's not a big deal. It's a big deal if there's bubbles in the tubing for a central line. Okay, we don't want any bubbles in the tubing. A, it can mess up the readings, but B, we do not want an air embolism. Okay. So, nursing interventions for a patient that is getting their CVP monitored. Okay, so you want to maintain a strict aseptic technique when you're inserting the catheter and doing any dressing changes. So this goes hand in hand with central lines, same thing. So we want to prevent infections. Regular assessment of the catheter site for signs of infection, redness, swelling, anything like that. You also want to be assessing for thrombosis. So if the patient has pain or swelling in the limb, you want to be able to make note and let your provider know and start interventions. So ensuring that the CVP monitoring system is properly zeroed and calibrated is also critical for obtaining accurate readings. Additionally, CVP should not be looked at in isolation, always considered alongside other hemodynamic data like blood pressure to get a comprehensive picture of actually what's going on with your patient. So pulmonary artery pressure. Okay, so what is it? It is a critical tool for assessing both the right and the left ventricular, so ventricle function. Okay, so both right and left ventricles and how well they're pumping out, right? So what it does is it measures the pressures within the pulmonary artery, and that will gain insights into how well the left side of the heart is functioning. The normal range for PAP is 15 to 25 systolic and 8 to 15 diastolic. Okay. Monitoring PAP is especially important in managing conditions like heart failure, pulmonary hypertension, where both the right and the left side of the heart might be compromised. This data helps us tailor and give specific interventions to support the patient's cardiovascular system as efficiently as we can. Okay, so some nursing interventions are you want to make sure the catheter placement is accurate. Now, we're not placing these, but we might be assisting when they place them. There's a little picture on the screen of kind of where it goes. It kind of looks like a central line too. That's the Swan-Ganz, remember. When you're assessing the waveform, if you'll have more like actual, if you go into the ICU or the OR, you will have more training on like what a normal waveform looks like and all that kind of stuff. So if it's off and it doesn't look normal, that means it might not be placed right and you would need to alert the physician. So you also need to be vigilant for complications like catheter migration or a rupture of the catheter, which is super serious. You also need to, as you're getting the readings off of the pulmonary artery pressure, you will adjust your interventions like medication administration and all those kind of things. So you need to be closely monitoring everything. So it often involves close collaboration with other healthcare teams, with your intensivists, which are your critical care doctors, and your respiratory therapy, and all of the above. Okay, so interpreting pulmonary artery pressure measurements is key to managing critically ill patients. A high PAP can indicate left-sided heart failure or pulmonary hypertension, where the pressures in the pulmonary circulation are elevated. On the other hand, a low PAP might suggest hypovolemia, where the patient has not enough blood volume, or right-sided heart failure. It's important to look at trends in pulmonary artery pressure readings over time, not just in like a single moment. So that will provide better insights into how well your treatments are actually working. Remember, pulmonary artery pressure readings should always be correlated with the clinical data and how your patient is looking. We're treating the patient, not the monitor. Okay. So some complications similar to the others. You can have the rupture migration infection. We already talked about those. There's always going to be a risk of, there's also a risk of infection and all those kind of things that we talked about for like the central line for the CVP as well as the ART line. So pulmonary infarction is also a serious risk if the catheter occludes in the pulmonary artery. If the catheter occludes or blocks off the pulmonary artery, that will cut off the blood flow to the lung tissue, and we can all surmise how that's not a good thing. Arrhythmias are another potential complication, particularly if the catheter irritates the myocardium. So if it's just kind of touching it and you already have like a super sensitive heart, it might cause some arrhythmias. There's also a risk of a pneumothorax during the insertion of the catheter, which is similar to the CVP monitoring and the central line placement. So be aware of these risks and watch out as you're monitoring things, and speak up if you think one of them is happening. So let's go back to that challenge question. So a patient with a CVP of 3 and a blood pressure of 88/58 is receiving diuretics. What should the nurse do next? Okay. So, what do you think the answer is? What do you think? So CVP of 3, remember what CVP is associated with? Fluid. Okay, so what's the normal range? Okay, and what's the normal range of a blood pressure? So is that blood pressure high, low, or normal? Okay, what else is in the question that we're looking at? Oh, they're giving a diuretic. What does a diuretic do? Makes a patient lose fluid volume in their system too, right? Okay, so we got to take these three things together. Now, what did you choose? Did you change your answer? Pause if you need to think this through. Okay, so the answer is administer a fluid bolus. If you chose B, you're right. Okay, so the patient's CVP is 3, which is technically normal, but it's on the lower end of normal, okay? Their blood pressure is low at 88/58. So, but it's like just slightly off of normal, but it is low. Okay, so we need to do something. So this suggests that the patient might be experiencing related to like something like hypovolemia or insufficient circulating blood volume. Okay, so especially in the context that they're getting a diuretic. Okay, so that diuretic is making them lose fluid. So the answer is B. Why? It is the most appropriate next step because it can help increase the intravascular volume, thereby improving that blood pressure and overall perfusion. The goal is to optimize the patient's hemodynamic status by ensuring adequate preload, which is the volume in the system, which is indicated by appropriate CVP and stable blood pressure. So why are the others wrong? So administering a vasopressor. So yes, their blood pressure is low, but while a vasopressor is used to increase blood pressure, they are typically indicated when there's a problem with vasodilation or vasoconstriction, or shock after optimizing fluid status. So administering a vasopressor without addressing the lack of volume of fluid in the tubes could exacerbate the problem by increasing vascular resistance without actually increasing the volume. So C, why is C wrong? So while assessing things, that's important, right? It's not the immediate action because the patient's blood pressure is low and you need a more urgent intervention to prevent more further like hemodynamics instability. So maybe some of you may have said stop the diuretic infusion, and why that one is wrong. Okay, so stopping the diuretic might be considered if there is a concern about volume depletion. However, this alone will not immediately address the low blood pressure or the potential hypovolemia. So they already have lost fluid. Their fluid is low, but it is within normal, right? And their blood pressure is low. So we need to get it up so that we can perfuse and send blood and oxygen and nutrients to all of the tissues in the body. So we need to do something to restore that first, right? If we just stop losing, so stopping the diuretic just means that we're going to stop losing. It doesn't mean we're going to be gaining, if that makes sense. So the immediate need is to restore the volume in the vasculature. Okay, so that's why we're going to give a fluid bolus. I will tell you on the same line, say your patient is in shock, right? We always, and we'll learn about this later, but just go with me on this. When your patient is in shock, like let's just say septic shock, they're super sick, their blood pressure is low, you're going to get a CVP. If that CVP is 3, you're going to be, and their blood pressure is low, you need to be flooding them with fluids because that CVP says that their blood pressure is low because their fluid volume status is low. But if that patient has a blood pressure of say like 76/40 and their CVP is at 15, it doesn't matter how much fluid you give them. It's not going to help their pressure. They already have enough fluid in the system. You need to give vasopressors. Like you need to give the meds that are going to cause vasoconstriction, and that will make the blood pressure go up. I hope that makes sense to you. So the CVP it really helps you determine what you need to do, fluids versus vasopressors if your blood pressure is low. Okay, moving on. So challenge question number 2, a lot like 1. Read it, pause, think about it, then we'll come back to it later. So a patient with a pulmonary artery catheter has a mixed venous oxygen saturation, SVO2, of 55%. What should the nurse do first? Increase the patient's oxygen flow rate, assess the patient for signs of decreased cardiac output, administer a fluid bolus, or prepare the patient for intubation. Stop, pause, think about it, and then let's move on. So waveform interpretation. So interpreting hemodynamic waveforms is another important skill for a critical care nurse. Arterial waveforms allow us to assess systolic and diastolic pressures in real time. Right atrial waveforms provide insight to right ventricular preload, which is the volume, while right ventricular waveforms give us a picture of right ventricular pressure. pulmonary artery waveforms are crucial for assessing left ventricular function and the pressures within the pulmonary circulation. The pulmonary artery occlusion waveforms, also known as wedge pressures, went over that before. So pulmonary artery occlusion, okay, also known as wedge pressures, help us estimate left atrial pressure. Understanding these waveforms will help you make informed decisions about patient care. So on here, just kind of, these are just some basic memorization of like what does what. So oxygen delivery and consumption. So these are some more important concepts in hemodynamic monitoring. So it goes beyond just what is their pulse ox, okay? Oxygen delivery, or DO2, is determined by cardiac output, hemoglobin levels, and arterial oxygen saturation. So what it essentially is the amount of oxygen being delivered to the tissue. Okay, so there's an actual equation for it. You do not have to memorize it. Just understand what DO2 is. It's basically how much oxygen is being delivered to the tissues. Okay, the oxygen consumption, which is VO2, is the amount of oxygen that is actually used by the tissues. So DO2 is how much is getting to the tissues, but VO2 is how much your tissues are actually using. Okay. So several factors affect that DO2, the top one, the delivery, including anemia. Because think about if the oxygen can't travel on the red blood cells, how is it going to get there, right? Hypoxemia and decreased cardiac output. On the other hand, the VO2 is influenced by things like fever, sepsis, and a patient's metabolic rate. It's more at the cellular level. So understanding these factors help better manage our patients, ensuring that they receive enough oxygen to meet the metabolic demands. Now, how do you get these measurements? A lot of times your monitor will do it and calculate it for you. It's not like a separate thing. It will be up on the screen, but you just need to understand the concepts. So SpO2 monitoring and oxygen assessment. Okay, so this is an important tool for assessing the balance between that delivery and the actual ability of the cells to use the oxygen that gets there, or another word for that is consumption of oxygen. So the SpO2, it's also known as mixed venous oxygen saturation, reflects the percentage of oxygen remaining in the blood after it passed through the tissues. So the normal range is 60 to 80%. A low SpO2 might indicate that the tissues are consuming more oxygen than is being delivered, or that delivery has decreased due to factors like low cardiac output. On the opposite side, a high SpO2 can suggest that the tissues are extracting less oxygen. They're not able to use the oxygen that's getting there, which might occur in conditions like sepsis or when oxygen is being over-delivered, okay? So monitoring SpO2 helps us fine-tune those specific interventions to optimize oxygen delivery and consumption. So we need to measure it because it's going to guide us in which way to what we actually need to do to treat why the oxygen is low. Okay. Now, this is measured through the Swan GANs. So the same thing as pulmonary artery pressure will give you an SpO2. So pharmacological management and critical care. This should be a review. If it's not, go and review. So do you remember learning about inotropes and those kind of things back in pharmacology? Hopefully you remember what it means, okay? But inotropes and vasodilators are commonly used to manage critical care patients that are hemodynamically unstable. So inotropes such as like dobutamine and milrinone increase cardiac contractility, making the heart pump more effectively. Vasodilators like nitroglycerin and sodium nitroprusside reduce the systemic vascular resistance, which help it improves cardiac output, and it helps lower and manage the hypertension. Those drugs are often used things like heart failure, shock, hypertension. And so it's super important to monitor the effects and hemodynamic parameters when you're giving these meds. This is kind of like a little intro. There's so many more meds that you need to monitor. We would never be giving like dobutamine without more advanced hemodynamic monitoring. We're not just going to have a blood pressure cuff on the arm and be giving dobutamine. We need Artline, those kind of things. Okay. So that's why this is brought into this lecture. So I want to just give you a little review. If you do not remember the difference between inotropes, chronotropes, stromatropes, this is just one way to classify drugs. If you don't remember, here's a beautiful little table that I made for you. So remember inotropes, okay? It's all about the strength of the squeeze of the pump, the strength of the heart squeezing out the blood. So the medications that are considered inotropes change how strongly your heart contracts and squeezes. Positive inotropes make the heart squeeze harder, which is helpful if the heart needs to push more blood out to the body. But the negative inotropes obviously do the opposite. They reduce the force, so it's kind of like a weaker squeeze. If the heart is working too hard. Okay. We want to kind of give the heart a break. We're able to perfuse like, why are you squeezing so hard, heart? You're okay. Let's just like lower you down a little. Okay. So chronotropes and dromotropes both deal with the speed of the heart's electrical system, but they do it in different ways. Okay. So where chronotropes, what they do is they affect the rate in which your heart beats primarily by acting on the SA node. So the master pulse generator. Chronotropes typically affect the SA node, and they're going to make it beat faster, and negative inotropes are going to make it beat slower by affecting the SA node. Where dromotropes are actually influencing the speed of the heart or how fast the heart's beating by affecting the AV node. So they speed up or slow down how fast the electricity goes through the heart. So they may make it slower or faster. So these things like calcium channel blockers and stuff like that, beta blockers, they make it where the electricity is slower to pass through the cells, which would lower the heart rate, right? Which in essence will lower the blood pressure if the heart rate's not beating as fast, right? So that's like a negative dromotrope. Whereas chronotropes, those are the things like atropine that's just going to make the heart it's going to make the SA node just actually go faster, more beat. It's going to generate the electrical pulse more fast. But the dromotrope is where it's allowing it to travel fast through the heart tissue to actually squeeze. I hope that's a good memory for you. Okay. Anyways, okay, so another two things I want to make sure you all know, I'm sure you know the difference between, but just make sure, vasopressors versus vasodilators. Think about the tube. If it gets bigger, and it's the same amount of fluid, the blood pressure goes down. But if you make the tube get smaller and there's the same amount of fluid inside, the blood pressure goes up. So vasopressor is the thing we do to increase blood pressure. Vasodilators are the things we use to decrease blood pressure. Okay. So talk about some kind of switching gears now, and we'll talk about holistic nursing standards. So it's what that is. And I know we talk about holistic nursing care a lot, but just as a reminder, you just need to provide care that addresses not just the physical needs, but also the emotional, spiritual needs of your patients. Okay. This ensures that the interventions that we're doing as nurses are centered around our patient. They're specific to our patient. It's not just that we're doing this because this is what we do with all of our patients. It's specific to their specific needs as the whole person, not just their medical condition. Okay. So this involves supporting the family as well as the patient. Okay. Because they support a super important role in that patient's well-being and the ability to advocate for the needs and wishes of the patient lying in the bed. Okay. Why this is in here is oftentimes, so these are more invasive monitoring, and you might have patients and family members that just don't want to be poked anymore. And so you need to educate them fully on like why we need this extra monitoring, why we need to do this, because without this med, like your blood pressure, we need to be able to monitor that. We need to place an art line because of this. And so like, it's important to understand these things when we're explaining why we're doing things, right? So remember, it's not just about the blood pressure and the med, like it's going to cause them pain, or it's another procedure. If it's a pediatric patient, like the mom may be like, no more pokes, but like explaining it, but ultimately they do have a choice, right? So take that into consideration when you're taking care of your patients. So medical calculations in critical care. So the bottom picture, I just had to put up there because I feel like so many of y'all think of that picture when you think that you're going to have to do calculations because it's just like a foreign language to you. And then I put the little like abacus counter on the other side because others of you that love math think it's so easy. Anyways, okay. So a lot of the meds that you are going to be given because of these more advanced hemodynamic monitoring they're like mics per kg per minute, micrograms per minute, that you're going to be titrating these meds. Okay. It's super important that you're able to calculate dose rate changes because oftentimes the order is going to be titrate the med to maintain a wedge pressure of this, or to maintain a CVP of that, or, whatever the case, or a map of this. And so like you will be watching the monitors and the continuous things. And as an ICU nurse, especially in the ICU, yes, you do it in the ER, but not nearly as often as in the ICU, you will be adjusting things based off these monitoring, and you need to be able to adjust and do math. Okay. It's important. Math saves lives. Okay. So the other thing is we need to also just make sure, while we're kind of on similar topics about IV push medications, there's slow push and there's rapid push. In the critical care setting, there are times when you want to literally hook up that syringe and just what we call slam it in. You push it fast. Epi is one of them. Adenosine, I talked about that in class, how you do it fast. Atropine, you do it fast. But a lot of things are slow. I will tell you right now, if you push mag sulfate fast, you're probably going to kill your patient. Like it will drop. Mag sulfate is a smooth muscle relaxer. It will drop their blood pressure so fast they might even have a stroke. Like, you don't want to do that, right? No, don't do that. So when you become familiar with the meds that we're going to be talking about in critical care, it's important to understand if you do this slow or if you do this fast. Those kind of things matter. Okay. And at the bottom, remember my little med acronym for what you need to know for administering meds. Okay. So it's important that you know which medications are commonly used for each method, like I just told you, right? So, being able to, the timing is super important because you need to be able to know what you're going to monitor for closely for the immediate effects and the potential adverse reactions. That's the E and the D of my med administration. That's the, like, what are the effects the expected effects? Like, what do I expect to see happening in my patient? And then also, like, what if things went bad, like, what would I see? Right? So that's the E and the D, the two questions you're going to ask yourself after you give a med, like, what am I going to look for? Okay. If you know those about any meds, you are going to be safe. Okay. So risks for improper IV medication administration. So we all know that once you push in the IV, you can't get it back, right? So, there can be some serious consequences. So administering too much medication too quickly obviously can lead to an overdose. You don't have a chance to think, oh, wait, that's too much. Let me not give it all. You're going to potentially overdose them, which could be life-threatening. On the opposite side, giving too little or giving it too slowly might be an undertreatment and you don't have the therapeutic benefit. An example, this is adenosine that you give an SVT. Remember, I told y'all the half-life is super short. So if you do it too slow, it's not going to work. It's not going to reach the heart and it won't have any therapeutic effect. It's not going to do what it was intended to do. So it's so important to know the timing differences. Okay. So ultimately, if you have an error, you can cause significant harm to the patient, and it can technically even be fatal. So it's so important for you guys to be meticulous in your medication calculations and also your administration techniques. So just make sure that you're paying attention and that you become familiar with the typical way that things are administered, or the typical signs and symptoms that you're going to look for, the expected ones and the bad ones, right? And then, so challenge question number 2. A patient with a pulmonary artery catheter has a mixed venous oxygen saturation, SpO2 of 55. What should the nurse do first? Pause, think about it. Now that you know about it, don't cheat. What did you say? Did you change your mind? So the correct answer is B. Okay, assess the patient for sign of decreased cardiac output. Why is it B? Okay. So a low SpO2 indicates that tissues are extracting more oxygen than usual, remember? And that's often because of decreased cardiac output. So in this case, the priority is going to be to assess for signs of hypotension, weak pulses, and decreased urine output, okay, to make sure that it matches up, right? Why is A wrong? So increase the patient's oxygen flow rate. So while increasing that might seem like kind of a logical step, it's not going to address the underlying issue of decreased cardiac output. C is wrong because though you might need to actually give fluids, the assessment should be done first to determine if the fluid volume is actually the issue. Okay. And then D, Preparing the patient for intubation. So it's not the first response that you're going to do unless the patient is in respiratory distress. And it didn't say anything about that in the question. So we cannot add that to the test question. You have to just assume everything is normal. You cannot make assumptions when you're taking an NCLEX test question. Okay. So the tip for this is you remember, and I know you guys know this, to always prioritize that assessment before intervention unless you need to do an immediate life-saving intervention. Okay. Especially when the data suggests that there's an underlying hemodynamic problem. Okay, so in summary, what some of the things that we talked about today about hemodynamic monitoring. So this is an important aspect of being an ICU nurse, being a critical care nurse, OR, ER, those kind of places. Okay, so when you monitor your patients in the more advanced ways, you're going to get better data to help you make better informed decisions when you're taking care of your patient. Okay, but don't forget that your nursing judgment and the clinical presentation of your patient is just as important. Okay, you always need to keep patient safety your top priority, particularly in the medication administration, where you need to be accurate with how you administer it and how you're calculating the doses. Okay. Also, remember that you just need to always be continuously learning and reflect on what you've done in practice and what like new things you encounter. Okay. So this is super important for staying current and staying up to date. Things change over time. There's new meds. We find out there's better way to do things. Don't just stick around and not learn and be willing to learn more things. Just because you graduate nursing school doesn't mean that you're done learning, right? I still learn every single day. And I really want to encourage you guys to just be lifelong learners. So that concludes Module 2A. Don't forget to review the reading assignments and kind of go over those learning objectives in the module before we have lecture. And happy studying.